3 times last night. That's how often you got up. And you wrote it off. Bad bladder, too much water at dinner, just getting older. Here's what a study published in Science in February 2025 found, when a nephrology team in Germany looked at what's actually happening inside female kidneys after 50. It's not the bladder. It's not aging in any generic sense, and the mechanism they identified changes what these nighttime wake-ups are actually telling you about your health. I want to walk you through 5 signs your kidneys are already sending. Signs that look like other things. Signs that most standard checkups completely miss. And I mean that literally, not as a figure of speech. Stay with the 5th one. That's the one that reframes everything.
The study I'm referencing was led by nephrologist Paola Romagnani. Her team published in Science in early 2025, and what they were looking at are cells called podocytes, the specialized filtering cells that sit inside the tiny capillary clusters of your kidneys and do the actual work of cleaning your blood. What they found is that women during their reproductive years have a significantly higher capacity to regenerate these cells, not marginally 5 times higher than men. Estrogen signaling drives this regeneration through specific renal progenitor cells that multiply and differentiate under hormonal influence. When that estrogen drops at menopause, the regeneration rate collapses to the same level as men. The 5 times advantage disappears. And the accumulated wear on those filtering cells, the microscopic damage that happens over decades, starts to outpace the body's ability to repair it. When I went through this research, and I've been sitting with it for a while, the part that kept coming back to me wasn't the biology, it was the timing. Because the regeneration collapse happens right at menopause, which is also when most women's annual blood work still looks reassuringly normal. There's a gap there. And the last sign on this list explains exactly why that gap exists and why the standard test your doctor orders is part of the problem. But first I want to show you what's at stake structurally. In the last video, we looked at what's happening to your arteries after 50, the stiffening, the reduced flexibility, the inflammation that accumulates. What I didn't have time to cover is where that arterial story goes next. Because your arteries and your kidneys aren't separate systems. They're in a relationship. And when one is struggling, it makes the other struggle harder. High blood pressure, which is often one of the first signs of arterial aging, damages the tiny capillaries inside your kidneys' filtering units. The kidneys, reading this as low blood flow, activate a hormonal stress response called the RRES system. That response tightens your blood vessels and tells your body to hold on to sodium and water. Blood pressure rises further, more capillary damage, more RRES activation. The loop closes. For women over 50, this cycle runs harder than it does in men of the same age. Before menopause, estrogen was doing 2 things simultaneously, helping your arteries stay flexible through nitric oxide production and protecting your kidney filtration through those podocyte regeneration pathways we just discussed. Both protections are gone now. The same deterioration that hits a man's kidneys in his 70s can reach a woman in her late 50s, years earlier, in a body that was never screened with that timeline in mind. A 2024 longitudinal study confirmed it in numbers. Women over 50 lost kidney function at 1.06 units per year versus 0.91 for men. Small difference. 10-year compounding is significant. Here are the 5 signs your body is using to signal that this process has already started. Most women who wake up 2 or more times a night assume it's an overactive bladder. It's one of the most common self-diagnoses in this age group, and clinically it's often the first explanation offered. But there's a kidney mechanism that produces an identical pattern, and it's called a loss of tubular concentration ability. Healthy kidneys have a circadian rhythm. At night, they receive hormonal signals to concentrate urine, to pull water back into the body, and reduce overnight output, so that you can sleep without interruption. This happens in the tubules, the long channels that follow each filtering unit, and reclaim what the body needs before the waste exits, as urine. When those tubules are damaged, which happens progressively as glomerular filtration declines, they lose the ability to maintain the osmotic gradient needed for this nighttime concentration. The kidneys produce diluted, high-volume urine at the same rate day and night. The result looks exactly like a bladder problem. The source is entirely different. And here's what's specifically relevant for women over 50. Estrogen receptors are expressed in the renal tubular cells themselves. Their decline after menopause contributes to this tubular dysfunction independently of any other damage that's occurring, which means the nighttime waking that many women notice in their early 50s isn't just hormonal, it's also renal. And one of those two causes gets addressed, the other doesn't. And this next one is the sign that I hear women describe most consistently as something they've been treating themselves for years, sometimes without anyone looking past the surface. You've switched products. You've tried fragrance-free everything. You've tried the thicker creams. The itch is still there, not localized, not related to a visible rash, worst at night, somewhere deep in the skin that no cream reaches. There's a name for this, uremic pruritus. And the mechanism explains exactly why topical treatment doesn't work. When kidney filtration declines, a class of waste products called protein-bound uremic toxins accumulate in the blood. The key one is indoxyl sulfate, a compound that your kidneys are supposed to filter out but can no longer clear efficiently. Because it's bound to proteins, it doesn't respond to standard removal methods. What it does is trigger the immune system. Specifically, it activates interleukin-31, a cytokine that directly stimulates itch receptors throughout the body, not just at the skin surface. The itch is neurological and systemic. It originates in the bloodstream, travels through the nervous system, and manifests as a skin sensation that the skin has nothing to do with. Research published in the Journal of the American Academy of Dermatology documented this pattern in early and moderate chronic kidney disease and consistently found that in women, this complaint appears years before kidney function is formally flagged on standard labs. It's one of the earliest soft signals, and it almost always gets sent to a dermatologist rather than a nephrologist. And this is where most women over 50 make the biggest mistake. They manage this for years as a skin condition, never connecting it to what the kidneys are trying to communicate. Restless leg syndrome affects somewhere between 15 and 25% of women over 50. In most clinical encounters, it gets categorized as idiopathic, meaning no known cause, or attributed to stress, poor sleep, or iron deficiency in isolation. The kidney connection is almost never made in a primary care setting, and it should be. Your kidneys produce a hormone called erythropoietin, EPO. It's the signal your body uses to manufacture red blood cells. As kidney function declines, EPO production drops. A mild anemia develops, and that anemia disrupts how iron is distributed in the brain's dopaminergic pathways, the circuits responsible for regulating involuntary movement, motor rest, and the sensation of physical stillness. Simultaneously, the accumulation of uremic toxins creates low-grade irritation in the peripheral nerves, the nerve endings throughout your legs and feet. The combination of dopaminergic disruption and peripheral nerve sensitivity is the exact biological substrate of secondary restless leg syndrome. In patients with known chronic kidney disease, the prevalence of secondary RLS is consistently documented between 20 and 30%. The critical problem is that in women whose kidney decline is still subclinical, still in the range where standard labs report nothing concerning, the restless legs are already present. The symptom is leading the diagnosis by years. Here's what's fascinating, and what most doctors never think to connect. The three signs we've covered so far, nocturia, uremic itch, restless legs, can all appear simultaneously in the same woman years before her creatinine level shows anything abnormal. That's not because her kidneys are fine, it's because the test is giving her a false floor. This one is quiet enough that many women spend months assuming it's a medication side effect, a change in taste with age, or a digestive issue, a metallic taste that doesn't go away, or a pronounced aversion to meat, not a preference change, not a gradual shift, but a sudden intolerance for a food that used to be completely fine. The clinical term is uremic dysgeusia, and the mechanism is specific enough that it's worth understanding, because once you know it, the symptom becomes unmistakable. When kidney filtration declines, blood urea nitrogen rises, even subtly, even within what most labs still report as normal. A portion of that circulating urea gets secreted directly into saliva through the salivary glands. Bacteria naturally present in the mouth, then break that urea down using an enzyme called urease. The product of that breakdown is ammonia. Ammonia alters your taste receptors directly, producing the metallic, bitter, or ammoniac quality that many women describe but can't quite name. The protein aversion is the body's logic working against the problem. Protein metabolism is the primary source of urea production. When the kidneys can't clear urea efficiently, something in the system begins generating an aversion to the foods producing more of it. It's a compensatory signal, an unglamorous one, and one that never gets correctly interpreted. This goes to a gastroenterologist or a dentist, or it gets filed under changes in my 50s and left there. Meanwhile, the filtration that's driving it continues its decline undetected. This last sign is the one I hear about the least, and it's the one I find most clinically striking. You're in a room that others find comfortable, and you're cold. You've had your thyroid checked. It was fine. You've assumed it's circulation, or just your personal baseline. Both of those are worth investigating. But there is a specific cold intolerance pattern that comes from kidney-related anemia, and it is distinct from thyroid or circulatory causes in a way that's worth understanding. The same EPO deficit we discussed in sign 3, the one that disrupts your legs, also disrupts your body's ability to generate and maintain heat. Red blood cells carry oxygen to every cell in your body. That oxygen is what powers the metabolic processes that produce body heat, what's called thermogenesis at the cellular level. When oxygen delivery drops even modestly due to mild anemia, the cells produce less heat. The body's internal thermostat becomes unreliable. For women over 50, there's already a pre-existing vulnerability here. Estrogen supported thermogenesis through its effect on metabolic rate and vascular tone, another function that declined at menopause. The kidney-driven anemia lands on a system that was already running cooler. The result is a cold intolerance that doesn't fully resolve no matter how many layers you add, because the cause is internal and biochemical. The clinical description is hypothermia of renal anemia. It is almost never considered in a standard clinical encounter because the anemia driving it is mild. It's below the threshold that triggers formal anemia workup, but it's consistent, and it's one more signal that the kidneys are not filtering at the capacity they appear to be filtering on paper, which brings me to exactly that problem, the paper, 5 signs: nocturia, uremic itch, restless legs, metallic taste, cold intolerance, 5 things your body may be doing right now that are being attributed to something other than the organ that's generating them. Before we close, there's one more piece, and this is the one that changes what you actually do after watching this. The test your doctor orders every year to assess your kidney function is called serum creatinine. It's used to calculate your eGFR, your estimated glomerular filtration rate, and for most women over 50, it comes back normal, or near normal, and the conversation ends there. Here's the problem. Creatinine is a waste product of muscle metabolism. Because women generally have less muscle mass than men, women produce less creatinine as a biological baseline, which means a woman can have meaningfully impaired kidney filtration and still maintain a creatinine level that sits comfortably within the reference range because her starting point was already lower than the male body. The normal range was largely built around. The equations labs use, including the updated CKD-EPI 2021 formula, attempt to correct for sex and age. But research has repeatedly shown they still underestimate filtration decline in older women, particularly lean women, sometimes by an entire disease stage. There's a different marker, Cystatin C. It's a protein produced at a steady, consistent rate by virtually every nucleated cell in the body. It doesn't vary based on muscle mass. It doesn't vary based on diet, activity, or body composition. It's a direct signal of how well the kidneys are actually filtering, not adjusted for body type. The 2024 KDIGO clinical guidelines formally recommended that Cystatin C be used alongside creatinine for more accurate staging of kidney disease, and the research supporting it is striking. When the eGFR calculated from Cystatin C is significantly lower than the one calculated from creatinine, that gap alone, independent of any other factor, is associated with 3 times the risk of all-cause mortality and heart failure, even in people whose creatinine-based labs read as perfectly fine. This is the part that bothers me the most about how this plays out in practice. Women experiencing some or all of those 5 signs go to their annual checkup, get told their kidney numbers look good, and leave with the impression that the kidneys aren't the issue. But the test that's generating that reassurance was designed without accounting for female physiology. And the 2025 research on podocyte regeneration makes clear that the biological decline in women begins significantly earlier and progresses through a mechanism the creatinine test can't detect. The women I hear from most consistently in this community describe exactly this: a pattern of worsening symptoms, normal labs, and no explanation. If that's you, this video is part of the explanation. What you can do is simple: not a supplement, not a protocol. One question at your next visit: can we add a Cystatin C measurement to my kidney panel? That single comparison, the gap between Cystatin C-based eGFR and creatinine-based eGFR, tells you something your creatinine number alone has never been able to tell you. One specific thing I want from the comments on this video: go look at your last blood panel or your most recent doctor's notes. Find 2 numbers, your serum creatinine and your systolic blood pressure, the top number from your most recent reading. Drop both of those below. What I'm looking for is the pattern the research describes: blood pressure that's drifting upward, creatinine that still looks normal on paper. That combination is exactly the window this research identifies. I want to see how many of you are already in it. Your liver runs the same silent pattern, and it shows up in your skin before any lab flags it. That's next. Everything I've shared today is for educational purposes only. Please talk to your doctor before making any changes to your health routine, especially if you're managing existing conditions or taking medications.